got an answer? Is it true?
Is it true?
Yeah, understand that if you have a skin in the middle ear, it's a skin which should not be there. So so if it should not be in the middle ear. Once it is in the middle ear, it starts desquamating and eroding the bones. So the cholesteatoma, it's that disease of the skin desquamating and making some destructive enzymes, and those enzymes will cause erosion of the bone, erosion of the structures, the nearby structures. Yeah. I think now it's true. It's okay with the it's okay with the middle ear, the outer canal, the pinna, middle ear, tympanic membrane, content of the middle ear, relations, the middle ear, and I think it's okay with this. So now let's go to the inner ear. So the inner ear is made by two important parts. One is the vestibular system, and the other one is by hearing. This one is the hearing system, and the other one is the balance system. Balance system will be located superiorly and posteriorly, while the hearing system is located anteroinferiorly. And what we can see is that the vestibular system is made by the vestibule and the semicircular canals. The vestibular system is made by two parts. One in the vestibule, the other one is the semicircular canals. So for the semicircular canals, we have the lateral, the posterior, and the superior. So the lateral horizontal semicircular canal, the lateral or horizontal semicircular canal, the superior semicircular canal, and the posterior semicircular canal. Those are responsible of movement. It's like angular movement. You see, you test on one side, you bend the head on one side or the other side. Those are the ones controlling that movement. And the vestibule now is positional movement. And when you see, we have the lateral semicircular canal, the posterior semicircular canal, and the superior semicircular canal. They communicate with the vestibule with the utricle and the circle. And those, the component of vestibular system, semicircular canals and the vestibule communicate with the cochlea. So this vestibular semicircular canal and the utricle and the circle, which is the vestibule, will be responsible for balance, and the cochlea is responsible of the hearing, and we are going to see later. So now, what you have to understand is that we have in vestibule and in cochlea and in semicircular canals, we have two chambers. We have the inner chamber and outer one. The inner chamber is filled with the perilymph. Perilymph is like CSF, cerebrospinal fluid. And the endolymph is the inner chamber. Inner chamber in the semicircular canal, the utricle, and in the cochlea is filled by another fluid which is called endolymph. So the perilymph is produced by the CSF, and the endolymph is produced by what we call the stria vascularis and duct cells, and is reabsorbed in the endolymphatic sac. So the endolymph produced by the stria vascularis circulate in the inner chambers and is taken into the endolymphatic sac, while the CSF, the perilymph is content of is like CSF circulating in the bony part of the inner ear. You understand that the endolymph is rich in potassium compared to the perilymph, which is rich in sodium. Maybe when you come to rotation, you will have a lot of practical thing. And we see all these structures on the bone, because when you do drilling, temporal bone drilling, we show all those structures. You show the lateral, the posterior, and the superior semicircular canals, and we see also the utricle and sacule, and you can also identify the cochlea. Now, if you go to the cochlea, the cochlea now is made by some chambers as well. It's like, you see the cochlea, it's like a shell. It's like a shell and turning around. It's like something turning around what we call an axis. So those round, those shell around an axis called the modulus. It has 3 chambers. The chambers include the scala vestibuli, what we call the scala vestibuli, and what we call the scala tympani. And in between the two scala vestibuli and scala tympani, there is what we call scala media. And the scala media is the one containing the hearing system, the hair cells, and the hair cells are the ones translating the mechanical energy from the sound collected by the pinna, sent to the tympanic membrane through the canal. Vibration of the ossicles send those mechanical energy into the middle ear, into the inner ear, and those mechanical energy reaches the scala media between the scala vestibuli and the scala tympani. And in the scala media, they found an organ called organ of Corti containing sensory cells. Those cells will now transduce the mechanical energy, that vibrating energy, to the electrical impulse, and the electrical impulse is transmitted to the brain for hearing. So the scala media is between the scala tympani and the scala vestibuli in the inner ear, in the cochlea, and the scala media has the organ of Corti. The organ of Corti transmit the hearing cells, the mechanical energy into the electrical impulse, and the electrical impulse transmitted to the brain for hearing. You see, if we cut one chamber, it will cut through the cochlea. We'll find 3 chambers. We find the scala vestibuli and the scala tympani, and in between there is a scala media with the organ of Corti with the sensory cells. Those sensory cells are the ones producing, translating the mechanical energy, the mechanical sound into the electrical impulse. The electrical impulse taken by the nerve to the brain. So this is what we wanted to translate. Just to note that the organ of Corti has around 13 cells and 13,000 cells, and those cells will be the ones translating the mechanical energy into the electrical impulses. And what we can talk about more is about you see, this organ of Corti, those are different cells. We are not obliged to know the cells. We know that just that the organ of Corti contains hair cells, the hair cells translating the mechanical impulse into mechanical energy into electrical impulse, and the electrical impulse taken by the vestibulocochlear nerve to the brain. So just the organ of Corti, what we have to know, there are different rows. This is what they show here, but there are different rows with the inner and outer hair cells. This is not important for us. That is what is important, that the organ of Corti transfer the mechanical impulse into electrical signal, which is going to be taken to the brain. So what you have to know again is that the blood supply to the cochlea is by labyrinthine artery, and the labyrinthine artery is a branch of inferior cerebral artery, and this is branch of basilar, and you go back and see where this is coming from. And what we have to know, that if there is a problem of blood supply to the cochlea, 15 seconds are enough to cause sudden hearing loss, sudden deafness. The ear can be dead just in 15 seconds if there is a problem of blood supply from this artery. So actually, this is what I wanted to talk about as far as the inner ear is concerned. To summarize, kindly understand that we have the vestibular system made by semicircular canals, the lateral, the superior, and the posterior, and also the vestibule made by the utricle and the circle. This part is about the balance, and the cochlea, which is responsible of hearing, with the 3 chambers, the scala vestibuli, scala media, scala tympani, and scala media in between. The scala media with the organ of Corti with the hair cells with inner and outer hair cells, translating the mechanical energy into electrical impulse, and the electrical impulse taken to the brain for hearing. And to understand that the blood supply is from the labyrinthine artery, and it's an end vessel. If there is a problem of blood supply through that artery, there is a risk of deafness in 15 seconds. Any questions so far? Because this was about now the inner ear. Any questions so far? So if there is no question, now we can proceed with just about examination. This one is about innervation of the auricle by greater auricular, lesser occipital auricular, or greater auricular, lesser occipital, auricular nerve, auriculotemporal, facial. This is something that you can understand, where these nerves are innervating and where they are arising from. This is not important for me, but you should know. So the concern, the most important that you have to have a look is about the examination, how to examine the ear. The examination of the ear, it's practical. It's just inspection, like other examination. Palpation, you can inspect, you can palpate, you can use the otoscope to see the tympanic membrane, the canal. You can do pneumatic otoscope just to see the mobility of the tympanic membrane. You can use a microscope. You can do vestibular function, test vestibular function. We are going to see how to make it. You can test the facial nerve. All of this, you will have them when you come for rotation. So those are ways of the examination. And hearing assessment is by tuning forks. You will see the tuning fork when you come for rotation. You see how the audiometric test is done, the tympanometry, acoustic reflex, echo, how to test the cochlea, cochleography, how to test the hearing in newborns, because for the adult we can use the audiometers, but for kids we use objective mechanisms, and these ones are auditory brainstem response and the autoacoustic emissions. Those are tests that you can do to test the kids or the ones who are not compliant with the audiometric test. So all of these tests you will have them when you come for your rotation. Those are kinds of hearing loss. These are results for how to stage the hearing by audiometry. Can classify into the mild in decibels, mild, moderate, severe, and profound. This is important for me. It's this one. This one, you take it importantly because it summarizes what we talked about. The sound are collected by the pinna, sent through the external auditory canal, vibrate the tympanic membrane, vibrate the ossicles, and sent to the inner ear. So up to this level, any problem, any issue impairing hearing at this level, impairing transmission of sound at this level is considered as conductive. So meaning we have conductive, we have three types of hearing loss. A hearing loss may be conductive. A hearing loss may be sensorineural, meaning the inner ear, the nerve, the cochlea, the nerve. And anything impairing this, like atresia or stenosis of the canal, like earwax, like foreign body hair, like perforation of tympanic membrane, like trauma to the ossicles, like infection in the middle ear. Whatever impair the transmission of sound at this level is called conductive. So then when you go into the cochlea and the nerve to the brain, this is called sensorineural. If you have a problem in the outer canal, or the middle ear, or the tympanic membrane, and there is a conductive, and we have another problem in the inner ear, both will be the mixed hearing loss, because it will include the sensorineural and the conductive one. this is clear. This is the audiometer. We will see how to do those assessment on audiometer between the sensory neural and the conductive. We'll see it once you come for rotation. Now, we've taken a bit about the anatomy, because we can't understand pathology without anatomy. So we can't understand how to assess the patient with a problem without anatomy. Reason why it was really understandable to start on the anatomy and the assessment. Now, we are going to be quick and go through the diseases, but don't worry, it's really clear once you understand the anatomy. So if you go to the diseases, of course, as I told you, we start by the diseases of the outer canal, diseases of the tympanic membrane, disease of the middle ear, disease of the inner ear, and especially diseases of the middle ear, because they are most common. So for me, otitis externa, it's common, but not really common. And what you have to understand, it's an inflammation of the outer canal or the auricle. This inflammation, if we talk about the inflammation, you understand? Inflammation means swelling, features of inflammation. You understand? Do you know the features of inflammation?
Yes.
Yes. So if you understand the features of inflammation, it's really very easy to understand, because any problem causing features of inflammation in the pinna or outer canal is otitis externa. And there are factors contributing to the otitis externa. Those include the following. Please note, you have to understand the factors influencing the inflammation of the outer ear, the pinna or ear canal. You see, absence of cerumen makes the ear canal dry, because the cerumen should humidify the outer canal. So absence of cerumen will cause inflammation. High humidity will cause inflammation, because there is proliferation of bacteria. Increased temperature, local trauma, all of this will cause inflammation. Allergies, chronic suppurative otitis media, infection, pass from the middle ear can cause inflammation of the outer ear. Swimmers, the one who swims, you understand you can contact the bacteria in the swimming pools. So in general, those are bacteria participating in the inflammation of the outer canal. Those are Pseudomonas aeruginosa and Staphylococcus aureus. Those are the main pathogens found in the inflammation of the infection of the outer ear. So there are different types of otitis externa. It may be diffuse, especially with the swimmers. It may be localized, just like a furuncle or a small abscess in the skin of the canal. It may be chronic. It may be eczematous like skin erosion, skin reaction. It may be eczematous. It may be necrotizing, just for extensive skin infection, destroying the skin. So those are types of otitis externa. It may be diffuse, like in the case of swimmers, in the case of fungal infection, which contracted in the swimming pools. It can be localized, the furuncle. It may be chronic. It may be just skin infection, skin inflammation, and it can be destructive, like in the case of a necrotizing disease of the skin, the ear canal, and the pinna. As I said, the bacteria involved are mainly the two are Pseudomonas aeruginosa or Staphylococcus aureus. And in 40%, sometimes we can't have the causative agent. They lack in 40%. And signs, of course, are signs of inflammation that we can understand. Everyone can understand that there is pain. If there is secretions in the canal, there is fullness, can itch, there is maybe itching, discharge, decreased hearing, tinnitus, fever, which is uncommon. It can be bilateral or unilateral. All of these are symptoms which may be signs and symptoms which may be in the case of the otitis externa. And this is I think this is clear. So the treatment consists of cleaning the canal, removing syringing if it's secretions if it's possible. You can apply local antiseptic. You can apply local antibiotics. You can apply cream antifungal if it's a fungal infection like in a diffuse otitis externa. You can give also oral antibiotics if there is a cellulitis, like in the case of Firanco. So apart from this infection, we can also have other causes, have other affection of the outer ear, like foreign bodies, like heat putting the foreign bodies, like wax infection, wax impaction, like other systemic disease, like in the case of zona, Lamsey-Hunt syndrome is zona, tumors. The zona means in the case of immunosuppressed patient, tumors, trauma, cyst, fistula, all of those are things which are not infection, but which may affect the ear, the outer ear. So is it clear with the outer, with the otitis externa and other conditions affecting the outer ear?
Question.
Yes.
Thank you. Teacher, we have seen that a person can suffer outer canal inflammation due to the absence of cerumen. And also back to the anterior bony part of the outer canal, there is no gland or hair, for instance, a gland that can secrete that cerumen. So I was wondering the adaptations of this anterior bony part of the outer canal to resist this inflammation that can occur due to the lack of cerumen.
Actually, as I said, the outer part has hairs and the glands. Their role is producing that fluid, but that fluid falls into the posterior part. Reason why, when you have like cerumen does not stay in the outer canal, in the anterior part. It goes also in the posterior part. When you remove the cerumen, we found it even impacted down deep, meaning that secretion is made to soften the canal is not staying just outside. It goes also inside, just to soften the inner part of the canal. So meaning, if there is dryness of the skin in the canal, it affects both parts because maybe those glands are not producing enough. Maybe the patient's physiology of the ear canal has the possibility of eliminating because the pathway of drainage of the outer canal is different from one patient to another. Even in that kind of producing mucus is different. Reason why, if some people produce much and the ear clean quickly, we don't have wax accumulation. But if some people produce much, have the much secretions, much gland producing mucus, and there is accumulation of cerumen, reason why cleaning is irregular. They come to see the doctor all the time for cleaning because there is accumulation of impacted wax. Others, they don't produce even, they produce little, and this leads to that dryness of the ear canal and cause inflammation. So there are two explanations. Some people, they produce much, and this mucus is retained the canal, both inner and out, anterior and the posterior. The bony and the cartilaginous, all of them are affected either by much production or even less production. So there is no problem of there is no the reason of staying on the one part, because whatever is produced in the anterior part goes into the posterior. If it's less, it leads to inflammation. If it's too much, it leads to accumulation or blockage on both sides, the inner part and the outer part. So now let's go to the middle ear. The middle ear is very, very important. The middle ear can be affected in 3 ways. One way is effusion. Effusion, as we said, effusion is from the proper improper working of the eustachian tube. If the eustachian tube does not work well, the consequence will be the effect on the eustachian tube either is open or is closed. If it's closed, the ventilation issue and pressure issue. If it's patulous or continuously open, risk of infection from the nasopharynx migrating upward in the middle ear. So this is one way. Either there is acute infection, pus in the middle ear, or there is sterile fluid in the middle ear in the case of effusion, or there is chronic infection with the perforation of the tympanic membrane, and then complication to the adjacent structures based on the anatomy that we talked about, the relationship with the middle ear and the other structures. So now, the infection in the middle ear, in the acute infection, may be viral or bacterial. So as you see, significant inflammation is present in the physical examination, both in the tympanic membrane, the middle ear, effusion, and there is purulence, meaning acute otitis media, there is purulent discharge in the middle ear without a perforation. If you look at the tympanic membrane, you will see that the tympanic membrane anatomy has changed. It's red. Normally it should be white. Now it's red because behind the tympanic membrane there is infection. There is pus, and the pus bulge on the pus flaccid, pus tensor. See how the number 4, the number 3, there is like bulging. It's like an abscess which is almost rupturing. So, as I said, the infection may be bacterial or viral. Bacterial, most of the time, bacterial is, as I said, for otitis externa, the pathogens are Staphylococcus and Staphylococcus aureus and Pseudomonas. But in the middle ear, the bacteria is mostly the Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. This will come all the time. All the time, those 3 germs are, you have to know them, because even the treatment, even antibiotic that you are going to prescribe will be prescribed depending on the pathogens. What you are antibiotic prescribed in the case of otitis externa is different from what you prescribe in the case of otitis media, because the pathogens are different. So other pathogens, you can also have staphylococcus and so on and so forth. But for me, what you have to keep in mind is that in 30%, sometimes you don't find the organisms, and 15 to 20% is viral. You have flu, and with your flu, it leads to the middle ear. And you know that flu is viral. So if flu is viral, now the otitis media that you are going to have will be viral, not bacterial. But viral may lead finally, if it persists, may lead to bacterial. So, of course, predisposing factor will include the age. You see, the acute otitis media mostly affect the kids less than 5 years. History of acute otitis media may be a predisposing factor. There are periods like winter where there is a viral infection with the change of weather. The ones with the bottle feeding, they have risk of having infection than the ones of, because bottle feeding, because the kids with the bottle feeding, there is the risk of even those milk to go into the middle ear. And even the way of using the eustachian tube is difficult, because the one who is chewing is different from the ones who is using the bottle feeding. The movement, the work movement of eustachian tube is, and ventilation of the middle ear is different. The kids working in the centers together with others, they have risk of transmitting the flu like disease than the ones not living in the daycare centers. Smoking, of course, living in an area where the smoking is, research have shown that this may lead to risk of otitis media. Those are some, you can choose one and the other one, but all of them are not really associated with hearing, with acute otitis media. So it's an infection in the middle ear. Of course, there is ear pain. Kids will be irritable. There is fever, hearing impairment, abnormal tympanic membrane, as we've seen on this picture, red tympanic membrane, bulging. Those are signs and symptoms found in the case of acute otitis media. So the treatment, of course, it's an infection. You give antibiotic based on the causes. Causes is Streptococcus pneumoniae. You give antibiotics, mostly the penicillin. You can the nasal drops, unless there are nasal congestion associated. The ear drops, there is no indication, because the infection is the middle ear, not in the outer ear. So putting drops in the ear canal is not important. And all the time, if you treat with antibiotics and give painkillers, paracetamol, and so on and so forth, and there is no improvement, please send to the ENT specialist, because this may lead to complications if there is no improvement. Any question about the middle ear, acute otitis media?
I have a question.
Yes.
That's the ventilation issue.
Sorry, I don't hear you.
As if the eustachian tube remains closed, there will be ventilation issue and negative pressure issue. And when it is opened, there is migration of infection. So when does it open? When does it close? And what it closed?
It's physiological. It's physiological, but it can also be pathological because when you swallow, the eustachian tube closes. Otherwise, what you swallow can migrate into the nasopharynx and go to the eustachian tube. When you are not swallowing, the eustachian tube kept open. So it closes while you are swallowing or chewing, doing any movement. But when you are not closing, or you're not swallowing, not doing any movement, any chewing movement, it is open. So now, if you have like kids with adenoids that we are going to see later, adenoids, kids with soft palate issues like the one with the cleft with the congenital malformation of eustachian with the soft palate, those with the nasal blockage, chronic nasal blockage, these also will impair the functioning of the eustachian tube, because if you have a mass in the nasopharynx where the eustachian tube opens, if you have adenoids blocking there, the eustachian tube will be closed. Not physiologically, but because of the disease. So, to answer to your question, the eustachian tube is open, not really patulous, not really quite open, but is open for a continuous drainage of middle ear content, while there is no any movement. So while there is chewing, swallowing, any movement of the soft palate and the oropharynx and the oral cavity, now the eustachian tube closes to protect the middle ear. This is how it happens. But as I said, it may be closed because of the disease, especially for upper airway tract infection, upper airway tract allergies, upper airway tract obstruction like adenoids and other diseases, polyps and other tumors. Okay. So now, this is otitis media with effusion. So I said we talked about acute otitis media in the case of infection in the middle ear, but also there is acute otitis media with effusion in the case there is fluid in the middle ear because of non-functional eustachian tube, negative pressure in the middle ear, accumulation of fluid in the middle ear, or eustachian tube dysfunction due to adenoids or other diseases blocking the drainage of the eustachian tube. This will cause fluid in the middle ear. And fluid on the middle ear will cause, this is physiological. If you understand the anatomy, everything is easy. If that drainage of the middle ear is not working, the fluid that the inner ear, the middle ear contain won't be discharged and will accumulate in the middle ear. And this is going to cause effusion in the middle, mucoid or serous fluid in the middle ear. So this middle ear fluid will cause impact on the tympanic membrane. Tympanic membrane won't move because there is accumulation of fluid in the middle ear. And of course, this fluid is sterile, it's not infected. If it's not infected, there is no pain. If it's not infected, the examination won't show a red tympanic membrane. It will show a white tympanic membrane, but with some air fluid level, what we call air fluid level. If you see, this tympanic membrane is not red, it's white, but if you see down, it is with like air fluid level. We have some fluid levels in the behind the tympanic membrane. This is otitis media with effusion. It's not red, it's not bulging, but there is air fluid level. This is because there is accumulation of sterile fluid in the middle ear because there is no drainage through the eustachian tube. So, as I said, blockage causes a blockage of eustachian tube either by upper airway infection, upper respiratory tract infection, allergies, non-healing otitis media, acute otitis media, adenoid hypertrophy can be the cause of eustachian tube dysfunction, a tumor in the nasopharynx, and eustachian tube insufficiency. Eustachian tube insufficiency is what we talked about in case of cleft palate. Those are causes which may cause the eustachian tube to be closed, not working properly. So this is important. And those causes will impair drainage of the eustachian tube, and drainage will cause accumulation of fluid in the middle ear, and accumulation of fluid in the middle ear will cause hearing impairment, oral fullness, and all of these symptoms of blocked ear. And this will be a problem because the hearing will be impaired. So the symptoms, of course, is what I talked about: blocked ear, hearing impairment, some sound in the ear. And when you see on the tympanic membrane, you will see a tympanic membrane with air effusion behind the tympanic membrane. But there is no redness, there is no bulging. So this is what is different from the acute otitis media. So the treatment, you understand, there is no antibiotic. Normally there is no antibiotic. There is no painkillers because there is no infection. So the treatment will be to treat the cause. Once the cause is no longer there, there is no adenoid, you remove them, you repair the insufficient of soft palate, you remove the tumor if it's there, you treat the upper respiratory tract infection, everything will be okay. If there is no improvement on the treatment of the cause, now we do surgery, which is called ventilation tube insertion. We open the tympanic membrane and aspirate that ear and that glue ear, that fluid, and put what we call a ventilation tube. And also, but also we do adenoidectomy. Most of our kids, so you have to remove the adenoids. We are going to see it when you see the nose and the paranasal sinuses, because we see what is the adenoids. So you see, now, if there is no improvement by treating the cause, we open the tympanic membrane, aspirate the fluid, and put some what we call ventilation tube. And this ventilation tube will get out itself after 6 months. So, of course, this is avoiding the predisposing factor. We don't delay on this. Those causative agents are the ones to avoid. Any issue, any question about this, about the middle ear effusion? So if there is no question about the middle ear effusion, so we talked about acute otitis media, now otitis media with the effusion, now chronic suppurative otitis media. So what you have to understand is that chronic otitis media, chronic suppurative otitis media, it's when there is infection greater than 6 weeks. And there is also a perforation tympanic membrane. For the previous otitis media, the acute and the otitis media with the effusion, there were no perforation. But now here we have a perforation and purulence for 6 weeks. But we have also to consider that there are chronic serous otitis media if the tympanic membrane is intact. So the chronicity is different. The chronicity for chronic suppurative otitis media is when there is a perforation and the purulent discharge for 6 weeks, at least for 6 weeks. And we have variation is when there is no perforation, but there is serous, there is otitis media with effusion lasting more than 6 weeks. This is another component. So what you have to understand, and this is all the time a question of exams, is type of chronic suppurative otitis media. The type of chronic suppurative otitis media are 2. One is safe. The second is unsafe. So what are the characteristics of safe? And what are the characteristics of unsafe? So the safe is in pars tensa. There is fluid, there is discharge, perforation, discharge lasting more than 6 weeks, but this is in pars tensa. And this is in communication with the Eustachian tube. So there is Eustachian tube communication, because the pars tensa is in communication with the Eustachian tube. Now, the unsafe is in the pars flaccida. We can even note it, the pars tensa. And now, here with unsafe is pars. And we say in pars flaccida, it's near the vessel, near the ossicles. Near the ossicles. Near the ossicles. So you have the safe or tubotympanic just in the pars flaccida, and unsafe and dangerous in articoantral just in the pars flaccida. You see? This is like a perforation in pars tensa, but this is a perforation in pars flaccida, multiple in pars flaccida. So when you have a perforation in the pars tensa, this is easy, but you have a perforation in pars flaccida, it's dangerous because it is an infection near the bones, and most of the times it shows that there is cholesteatoma. There is skin in a wrong place destroying the bones. So the pathophysiology, it's Eustachian tube dysfunction. Just take in mind that there is Eustachian tube dysfunction. There is Eustachian tube dysfunction and leading to accumulation of fluid in the middle ear, infection of middle ear, perforation and persisting perforation. And most of the time we say that this is due to retraction pockets. If it's cholesteatoma, it's retraction pockets. So there is Eustachian tube obstruction, negative pressure in the middle ear, collapse of pars flaccida, atelectasis of the pars tensa, and retraction of pocket formation in the attic, and the cholesteatoma formation. So this is okay for me. This is enough, and those are pathogens. Mostly is like the pathogens in the otitis externa. This is Pseudomonas aeruginosa and Staphylococcus aureus. Those are the main pathogens.